Hello, my name is Jenny Arnold, and I'm the Director of Practice Development for the Washington State Pharmacy Association. Thank you so much for your interest in the Clinical Community Pharmacist program. It has been a great opportunity to see this rolled out across Washington State, and we welcome other states and other pharmacies adopting this program as essential to taking care of patients in their communities. Today, I'd like to review the fundamentals of the training program, the development of the program, and then the toolkit that comes along to help implement this program in your pharmacy. I want to take a moment to just paint the picture. We've all been there before. A young woman comes to us on a Friday afternoon with clear symptoms of a urinary tract infection. Perhaps she's had one before and can self-identify the symptoms. Perhaps it's your clinical judgment that believes that she has a urinary tract infection. But what can you offer her? Your sympathy? Recommend phenazopyridine? Perhaps see if cranberry juice, the real, not the cocktail, might help her symptoms? Could we possibly do more in the community pharmacy? Could we have somewhere to recommend that family member to go to get care besides the emergency room? We think so. Beverly Schaefer, a pharmacist and owner of Caterman's Pharmacy in Seattle, thinks that pharmacists can do more. She's seen these patients in her pharmacy and was testifying before the FDA's third class of drugs inquiry about the role of community pharmacists being able to increase access to care. Other presentations on a third class were including considerations for medications could be sold in a kiosk after answering questions on the screen, or medications that could be dispensed somewhere between over-the-counter versus prescription only. Once she left the hearing, she had a feeling it would be a long time before the FDA approved a pharmacist class of medications, and thought perhaps we can use collaborative practice agreements to be able to address the needs of pharmacists in community pharmacies now. And that was the beginning of the Clinical Community Pharmacist. The Washington State Pharmacy Association partnered with faculty and students from the University of Washington School of Pharmacy and the Washington State University College of Pharmacy, as well as pharmacists and physician partners from across the state to develop the training programs and toolkit. We created a training program for pharmacists that is on demand and is written in nature. This way the pharmacist can easily take the training in their free time and use the written modules to refresh themselves on clinical decision points when they have patients in the pharmacy or questions. The focus is for pharmacists as prescribers and as providers. It doesn't reteach the pharmacists about Cipro, for instance, for UTI, but it does help them understand when a UTI is a UTI and when a UTI isn't a UTI and they need to refer a patient. I've had many pharmacists over the years say, send a patient with a UTI my way. I know how to treat a UTI, and that is absolutely the case. But they need to know when a UTI is not a UTI and when they need to refer the patient instead of treat. That's the focus of the modules, not retraining the pharmacist on the information they already know. The training is broken up into two main chunks. The first training is on the fundamentals. This is required for any pharmacist taking the training. It reviews the background of the clinical community pharmacist, business planning, which is inclusive of how to market your program, how to find a physician partner, how to develop a pricing strategy, and more. Very essential for success of the program. It also describes how to use collaborative practice agreements and identify a physician partner, disease identification standards, ethical standards, and documentation, among other essential pearls of wisdom for every clinical community pharmacist. Once the pharmacist has completed the fundamentals training, they can move on to the clinical modules. The clinical modules are more a la carte. The pharmacist can take all of the trainings or just the ones that they think are important to their pharmacy practice. The clinical modules are broken up into two main categories, either acute conditions or prescribing new therapies versus refills. Each clinical module goes through a disease state review, as well as reviewing related disease states so that the pharmacist can make the differential diagnosis, or at least understand when the disease that's presenting isn't actually the disease that the pharmacist can treat. These are also similar to referral flags. When is the disease potentially too severe or unrelated for the pharmacist to treat, and the patient really needs to be referred? Therapeutic options and decision points for selecting therapy versus referral. As I previously mentioned, the clinical modules are broken up into acute conditions or provision of new therapy versus refills. For the acute conditions, they include all of these listed on the right-hand side: allergic rhinitis treatment, anaphylaxis treatment, which could include the treatment of acute anaphylactic reaction, but much more likely the provision of an epinephrine autoinjector based on the patient's clinical history, burns, treatment of minor burns, headaches including migraine, human canine feline bite prophylaxis, which is a great opportunity to partner with nearby veterinary clinics to send patients who've been involved in an animal bite attack and maybe bit themselves for treatment, oral fluoride provision, herpes zoster treatment, insect sting treatment, swimmer's ear treatment, urinary tract infection treatment, or vaginal yeast infection treatment with a one-dose oral medication. The therapy that we see used the very most, or what the clinical community pharmacist is called upon the most to treat, tends to be the urinary tract infection. This is the most common infection in women, and so being able to quickly and easily access treatment is a great opportunity for patients in our community. For providing refill authorization, the clinical community pharmacist content focused on the things where it was difficult to give an emergency supply of. Epinephrine autoinjectors are difficult to give an emergency refill for, and patients oftentimes need them when they're on vacation or traveling, so the pharmacist being able to refill a prescription is very important. The provision of inhalers and an albuterol inhaler, again for maybe a traveling patient or a patient who's run out of refills, is essential and can prevent emergency room visits, just like having access to an epinephrine pen. Contraception is difficult to refill, but patients can be in an awkward situation when their pack runs out of refills. So being able to provide a refill of this medication is important. And then insulin refills. Insulin is expensive and difficult to give an emergency supply of, but so essential to patients. So the pharmacist being able to prescribe it is very important. As G.I. Joe said, knowing is half the battle. Providing these trainings is very important to implementing the clinical community pharmacist, but it's only half the step for implementation. The other part is how do you successfully implement this in the pharmacy and all of the support documents necessary. So the clinical community pharmacist team developed a toolkit to help ease the implementation burden. The toolkit contains patient information forms and intake forms customized for every disease state, pharmacist documentation forms for each disease state with important decision point documentation and documentation of which therapy was prescribed, model collaborative practice agreements, and patient handouts to explain to patients what to do if their disease doesn't get better, non-pharmacologic therapies that may also help, and more information to follow up with the pharmacist's information provided during the visit. All of these forms are in Word form so that they can be customized to your practice setting and adjusted depending on the preferences of your physician partner. So how do you get started? where do you go for more information? You can visit www.wsparx.org/page/CCP for all the information on the clinical community pharmacist, including how to register for the training and obtain the toolkit. I and the entire clinical community pharmacist team would like to thank the Community Pharmacy Foundation for their support of this project. Their dedication to promoting the clinical community pharmacists as an opportunity for community pharmacists to better serve their patients has been essential to the success of this project. We couldn't thank them enough. For more information, please reach out to me. My email is jenny@wsparx.org. My phone number is listed there. I would be happy to talk with you about how to offer this training through your state association or to a large group of pharmacists. Please reach out to me. I'd love to help make this a service that you find in your pharmacy. Thank you.